It's me, Sandeep. It's a real case. I just obviously changed the name a little bit. So he's a 42-year-old gentleman, engineer from India. He's known with hypertension, dyslipidemia, obesity. He does not have diabetes, but he has pre-diabetes. He's a family history of type 2 diabetes and cardiovascular disease. Current medications, very typical ones that we see in Canada. I'm guessing it's also similar in Europe as well. Lodipine 5 milligrams, perindopril 8, atorvastatin 20, metformin 1,000 milligrams BID, and gliclazide MR 30 milligrams once a day. And if you look at his exam and labs, you can see that his BMI is elevated at 33, blood pressure, and it's actually quite elevated given the fact that he's actually a South Asian descent. Blood pressure is 134 over 78, A1C as a typical pre-diabetic patient, 6.3, LDL 1.8, and then eGFR seems to be fine. Now, the ALT and AST is interesting. So ALT is 40 and the AST is 42 with a platelet 165. So those are two liver enzymes as well as a platelet will show on the lab form that it's actually normal. So let's talk about Sandeep because I had an interesting encounter with him. And he turned out to be someone who I never suspected to have a liver problem a couple of years ago, and now we know that he actually has a advanced disease, liver disease. So I guess the first question I would like to ask is to Dr. Cragg. Is there other, or sorry, I should say, are there any other risk factors for MASLD or MASH, especially when you see someone like this in your clinic?
I think you captured them very well there. Of course, it's all related to metabolic syndrome. He seems to have them all. Hypertension is strong, of course, obesity, prediabetes, insulin sensitivity, but also dyslipidemia and the high BMI, his family history, his age. But then, of course, I mentioned also is alcohol, because alcohol can
Hmm.
be maybe 5 to 10 times as toxic in a person like that than if you have a person without all these factors there. So that would be an even small amounts of alcohol actually fits within the MASLD criteria, which is 2 or 3 units today, 3 units a day for or 30 grams for a guy is quite significant. I don't know, but it's worth asking him.
Okay.
Otherwise, I would, I don't know if you want to go into the biomarkers, but again, for he is a really high risk patient, also given his age.
Yes. Yeah. So I was told by my friends from India. So before I was more familiar with the Indian people, I was told that they actually drink a lot of alcohol, a lot more than we think. So I work in the in an area where there are a lot of ethnic immigrants, for a lot of people from South Asia, and apparently this pocket that I work has the highest alcohol consumptions in the area that I live. So there was something enlightening. And just for FYI, I'm from Korea originally, and we are used to, I don't know if it's still the case, hold the proud label of the highest alcohol drinkers in the world. And I was like, no, that's not possible. You cannot be Germans and Russians. But, but apparently we did. So this is stereotype that the Asians eat healthy and drink healthy. I think it's not the case anymore. Yeah. So then, Dr. Vlad, Dr. Ratio, this patient has a what seems like a normal ALT and AST, and the platelet looks okay. I mean, at least on our lab form, it's our results is not going to be flagged for sure. But do these results concern you? And if you can, if it does, and can just explain why.
Yeah, I think there's a mistake in the ALT because it can't be reference can't be 40 to 129, so it's probably less than 40. And the AST is reference upper limit of normal less than 50. So this raises an important question, which is that many labs have normal values that are too high because they have sort of historical values that were most of them established in the 50s or the 60s when people were not as fat, when people did not have some of the diseases that we have today. So the population values were different at that time. So there's a lot of literature now saying that healthy ALT values should be much lower than that. So
Hmm.
probably this individual has, although you have to retest to make sure persistently increased. This individual probably has slightly increased aminotransferase despite the reference that the lab provides you with. So that's one thing. The other thing that is interesting is that a patient like that in our country, which devotes a lot of money for clinical care, we would have done an ultrasound. Maybe it'll show later, but the demonstration of steatosis is something that is a very strong factor that would trigger additional explorations here. Now, you can argue based on the guidelines that simply having these cardiometabolic risk factors is sufficient to start investigating the liver. We usually try to make sure that there is steatosis on ultrasound. Of course, not all diabetics have steatosis, only maybe 70% of them. And of course, ultrasound is not very sensitive. So maybe in the end, it doesn't serve any purpose, but that is for the patient, from the patient perspective, is very important, because then we show him that the liver is full of fat on the ultrasound, and then he starts taking the disease more seriously.
So, American Gastroenterology Association, if I'm not mistaken, they suggested that ALT and AST numbers, the normal value should be actually less than 35 and 30, depending on the sex. Does that resonate with you in your practice, that the ALT should be maybe a bit less than like normal value of 40s or 50s?
Yeah, that's what I said, and probably even lower for women.
Okay.
I think also the fact that AST is higher than ALT also gives you an impression that there's cirrhosis or fibrosis. And I think if you calculate it at FIB4, it will definitely go beyond our normal threshold of 1.3.
Okay. Awesome. Well, thank you. So, I'm because I know nothing about diet. Well, I don't know much about the liver, but I really know nothing about diet. And my dietitian friends are exposing me big time right now that I don't know much. So, Dr. Shira, what is an appropriate diet? I mean, we talk about Mediterranean diet, and you go to Korean 60-year-old males that, hey, you should be on Mediterranean diet. They'll be like, sure. And they'll come back and they said, there's no way I can eat this because this is not possible and it is not feasible with the food that I eat. So how would you recommend patients for someone like this who actually has MASH? So what would be the MASH diet in a non-white populations?
I'm really happy for this question, because we keep saying Mediterranean diet, but it's not suitable to many cultures and other dietary patterns, and we really need to tailor it to the patients, right? There's no point in even the term itself, Mediterranean diet, gives a patient a feeling like you don't speak in his language, you don't understand his dietary habits. So we need, actually, I think we need to not to call it a Mediterranean diet. It can be a healthy, low sugar, low saturated fat diet and not Mediterranean. We should switch the term to something else that is more multicultural. And I think that many of the principles of this diet can be kept in different cultures and different types of diet, because Mediterranean diet really puts an emphasis, first of all, on low sugar diet. And we mentioned here the need to assess the consumption of alcohol. So there is another important drink we should assess, and these are the sugar beverages. Always ask the patients about the sugar beverages consumption. Also, especially among those with normal weight, by the way, which tend to drink sugar beverages, from my experience, and there's also little research about it. So low sugar diet you can do in any culture. Avoiding sugar beverages you can do in any culture. And then you need to ask a lot of questions. You need to understand what the patient eats, what are his eating habits, and then you can really capture how you can tailor the diet to his needs and cultural needs, even economic needs, because we know that many patients have food insecurity. So you cannot recommend a diet that is too expensive to keep, especially in the long term. So we need to ask a lot of questions, what the patient eats, and see how we can reduce the amount of saturated fat, reduce the amount of ultra-processed food that I mentioned, and reduce the amount of sugar. One last comment, don't use just a weight focused approach. It's true that the most evidence-based treatment is weight reduction. There is no argument about it. But we can't focus only on weight because we know that many patients have tried many times to reduce weight and feel that they failed and are unwilling to discuss it again. So if you only focus on weight, you kind of lose them within these discussions. So we need to discuss, not less important, diet quality and physical activity.
Thank you. That's such an insightful comment. And in Canada, in the obesity world, we're actually moving away from the BMI and looking at the scale as the marker of success. We're looking at the function. So is there improvement of function? And as many of you may know, we are now using a waist to height ratio of a zero point 0.5. So it doesn't matter what gender you are. It doesn't matter what race you are. If it's greater than 0.5, then that's a metabolically not good. So that's kind of where we're moving towards. So yeah, but it's just so easy, in the clinic to use a BMI because
Right.
just yeah, yeah. So no, thank you for that excellent comment. Ms. Kitely,
Can I just make one comment? I suppose it's
yeah.
just in Ireland, our third biggest ethnic population is actually from India now, and a lot of my colleagues are Indian, and they would tend to, particularly at the weekends, stay up late. So with the time difference, that they can eat a meal with their family remotely at home.
Mhm.
So,
Oh.
even to maybe like broach what Shira said earlier about the intermittent fasting, because sometimes
Mhm.
even the meal times that they're trying to follow don't go with the time clock, the timeline that we're on. And especially about the sugary drinks, like we would, we drink a lot of tea, and then our Indian colleagues drink an awful lot of sweet chai, and there's a
Mhm.
huge amount of sugar in it, and it's lovely. But the way we would, there's, the sugary drinks are not always the fizzy drinks that we associate in the Western world as being the bad drinks. So it's just a comment.
It's really
Okay.
important comment. It shows how important it is to get familiar with your patient and to
No, that.
ask a lot of open questions and just listen to him in the first time you meet.
Yeah, once again, listening to the patient. Awesome. Yeah, that's a key. So Ms. Kitely, I have a very, very important question to ask you because I think as a healthcare providers, we make a lot of mistakes in terms of the choice of words and languages that we use. So, what line or language should we use when discussing with patients about this whole MASH?
I think, as Shira said, bringing up, is now a good time to talk about your diet, because we all have off days. You come in, you're stressed,
Hmm.
last minute out the door, and just sometimes it's not a good day. And I suppose the other thing is to be aware, like, uh, you know, has there been any triggers that have changed how you're approaching your disease? Have you been under any additional stresses? Because sometimes, this phrase, like, I fell off the wagon, is
Hmm.
not good. It's kind of better to say, did anything happen that triggered, a change in how you're able to manage your condition? I think something like that is always a much more open-ended way to approach that subject. And something I've learned from my own child who has a medical condition, but he would say that, he's only a child, but he would say, um, the doctors always say, "Do you understand?" And his point of view is that it's actually not if he's understood it or not. It's has it been explained to him in a way that he can understand. Because that's what the
Hmm.
teachers say in school. They don't say, "Do you understand?" Yes or no. They actually say, have you understood that? Or will I explain it in a different way? So sometimes, especially when you're going through labs and data, and it's two different languages from the patient and the doctor, I think that kind of non-patient blaming, if they want to ask you to repeat parts of the conversation, I think is very important too.
Oh, that's a very insightful comment, really. In diabetes, we are also trying to use the word, at least in Diabetes Canada, we are trying to use the word to avoid the feeling of blame, that a failure for the patient. So, for example, like you're not going onto an insulin, and a lot of people feel that they have failed themselves. So those are word choices and language. I think is very important. Dr. Shira, I had a one patient who asked me very recently that. The sugary drinks are bad and fructose is bad. However, there are lots of fructose in fruits. So is that okay?
It's the most common question that I get, I think, in any conference. Yes, fruits are okay. There's a big difference between the juice or fruit juice that contains a lot of fruits without the fibers.
Hmm.
So you get a huge amount of sugar in one glass or one can without all the fibers to reduce the rate of absorption of the sugar. So there's a huge difference. So yes, so sugared beverages or fruit juice are bad, but fruit eaten in a reasonable amount, 2 to 3 portions per day, is fine for most patients. And in my 25 years as a dietitian, I never met a patient who got obese or any kind of liver disease because he was eating 3 fruits per day. Usually, the bad stuff and the sugar, the huge amounts of sugar, come from ultra processed food usually, and not from fresh food.
Yeah. And those are usually easier to access and cheaper as well. Yeah. So
Absolutely. That's
it's a
that's
bit
a
of a
big
challenge.
issue. The price, yeah, the fruits and vegetables are extremely expensive in most
Yeah.
places.
Oh, geez. I feel like I can just listen to all of yours the whole day. Maybe we should ask Mike to gather together in person somewhere warm.
Good idea.
Yeah. And just listen to just word of wisdoms and your practical pearls because these are just really, really valuable to all the primary carers. It's been very valuable for me. And I'm sure it's been quite valuable for a lot of our listeners. So thank you so much once again. And so I guess it's time to hand over to Mike.
Thank you.
And you can, whoops, and you can hear me okay, right? Unmute. Yep. All good. You can hear me, Vlad?
Yep.
Okay, good. All right. Well, thank you, James, and thank you for that excellent panel. Thank you all for joining us and for your engagement throughout this European Mast Cell MASH Summit. Tonight, we focused on what is essential for improving outcomes across Europe, recognizing mast cell and MASH earlier, integrating simple non-invasive tools into everyday practice, understanding patient barriers, stigma, and the lived experience, delivering realistic lifestyle guidance, and aligning metabolic and liver care in a way that works within real world European systems. Primary care is the first line of defense against advanced liver disease. You are the clinicians most likely to encounter mast cell MASH early, often before symptoms appear. When risk is recognized sooner and supportive conversations begin earlier, patients have a far better chance of preventing disease progression. What you learned tonight will help more people receive timely assessment, clearer guidance, and a path toward better metabolic health. It will also help reach those who do not yet even know that they have mast cell or MASH, a population that remains far larger than those diagnosed. On behalf of the Fatty Liver Alliance, thank you to Jeff Lazarus, our fantastic moderator, our very passionate and informative presenters, our partners, and to each of you for the vital work you do every day. Together, we are strengthening primary care as the anchor of liver health across Europe. Wishing you all a very good evening, and thank you once again for being part of this very important conversation. Thank you.
Thank you.
You.
Thanks for organizing.